So I'm really excited for this one today. I didn't let you know off camera, but I am actually really excited for this one today. We're joined by Professor Lennard Funk, a highly respected shoulder surgeon, specialising in sports injuries and soft tissue injuries. Over 100 published articles, books. Hopefully, I get this right. Is it the shoulderdoc.co.uk? One of the leading.
.co.uk, that's the
There we
key.
go.
Not the .com, that's owned by internet pirates.
Yeah, I've used that website quite a few times going through. It's a very good bit of information. Anybody struggling with shoulder pain that they can access as well. So it's great to have you with us today, Leonard. Thank you very much for joining us.
Brilliant, absolute pleasure. Thank you for asking me.
Yeah, lovely.
Anything
And,
I can do to help.
perfect. As we spoke off camera, the podcast previous to this one of the athletes that I worked with, we actually sent him to you for his shoulder surgery. So, and he's had zero issues and he gets zero kind of repercussions from that, and he's very, very happy with the way he was treated. So it's good to get your perspective on a different side of things that people don't usually see.
Thank goodness, I knew there was one.
This is it. Can you tell us, Leonard, then can you tell us from your perspective who you are and what you do day to day as an orthopedic surgeon?
Well, I'm just a shoulder surgeon now, and I only do predominantly sports and soft tissue shoulder surgery. So very limited area even of shoulder surgery. So and that's what I do. I just treat soft tissue shoulder problems, both shoulders at the moment.
Both shoulders. What drew you specifically to working with athletes then and sporting injuries? What sent you down that pathway?
Um, Accidental, not intentional, really. But when you look back at it, all the pieces fit into place, how it happened. So, in a nutshell, I had a background in doing, obviously, in playing sports, and then doing a BSc in sports physiology and biochemistry. Then working in physiotherapy, starting physio, then taking a real interest in orthopedics. And then when I became a consultant, I guess the big thing was that one of my colleagues, Sam Jari, who's a knee surgeon, had come back from America where he'd seen the sports medicine set up in America. And him and Henry Maxwell in Manchester asked me to do the upper limbs for their sports medicine clinic. And I guess that's what got me introduced to many athletes and clubs off the back of that. And that just led to progression. Then then working with certain physiotherapists, we then got into doing a lot of research and teaching with on the rehab side of things, as well as surgical.
So you mentioned there the sports medicine side overseas in America. Is there any difference between the sports medicine side over in the UK and in America? Is it?
Yes, I think there's a big difference. It's very surgeon led, so that's why Sanj came back with that, as opposed to here where it's sports medicine is a completely different speciality. It's actually medicine, and a lot of the sports medical injury side of things is run by the therapist primarily in sports,
Yeah.
supported by whereas over there it's all led by orthopedic surgeons. But I think that's also starting to change. There are more sports medicine specialists coming.
Do you see? Well, from my point of view, from what I do, I see that as the better way to do it from the medicine side first before surgery. How come? Do you know why they adopted that way around over there? Do they find it works better for them, or is it just?
I think it's historical because sports injuries, have always been dealt with primarily by orthopedic surgeons because they've been around for a very long time. And in America, physiotherapy has traditionally been prescribed like a drug. So the physiotherapists don't, as far as I've seen and know, don't work as autonomously traditionally as in the UK. So that's really how it's been traditionally in
That's a good,
America, whereas in the UK, it's been a very different setup.
yeah, it's a good perspective to look at. I didn't even realise that perspective. I've not ventured overseas yet. Hopefully, I can do that in time to come. But it's
St-
yeah,
Stay here, it's better.
it's better. The weather might be better over there, but at least I love the sport over here.
Exactly. No, not
So
much rugby league over there.
no, well, there is. I know there's a few teams, New York and
Hmm.
things like that, emerging. Whether that comes to anything, hopefully it does. But it would be a great sport to be out there. I think
Hmm.
they'd really engage with it well. Um, so when obviously I've sent a few athletes that I've been with and worked with to yourself. I've
Hmm.
not actually been present in those consultations. That's due to time constraints with the part-time position that I was in. But
That's
what do athletes usually ask you in that first consultation that they're in after a serious injury? What goes through their head, and how do you approach that with them?
So, I mean, the predominantly number of young athletes, it's all about when can I get back.
Yeah,
It's not about how much pain they're in. They are tough, and the highest level, it's not. That's not. It's all about when can I get back. So it's then working with them in the best way to achieve their specific goals. Uh, like I always say, you treat the man, not the scan. So it's about what is in their best interest for them to achieve their goals and to return to play in the safest way, not necessarily the quickest way.
yeah. Well, how do you approach then the a
Yeah.
balance between honesty and hope? Because that player's going to hope
Mm,
you can do something magic and have them back in 2 weeks, and that probably
mm.
won't be the case with most injuries that are put in front of you. So how do you balance
Well,
that with honesty?
Well, the brilliant thing is with almost all professional athletes, in the UK we're very lucky because they have fantastic team therapists. So a lot of them will have been primed before they get to me, and a lot of the discussions will have been had before they get to me. And I think by getting to me, it's sometimes reinforcing and also understanding the risks. Of surgery, the surgical options, and the timing thereof. So, um, the in terms of the players, they may sometimes come with a terrible idea, thinking they have to have surgery, and then it's fantastic for them when they find out that they don't. So there's a lot of that, um, and sometimes that's very rare that it's an injury that has to have surgery and can't get back, and it's very rare. It's usually it's about decision making, combined decision making, and very much it's the patient factors, which is their age, the type of sport they do, the type of position they play in, um, their then the their club or their team factors, where they fit in with that, where the time of the season is, if it's early season, mid season, then the injury and what is the type of injury and the implications of the different treatment options for that injury, pros and cons. And then, very importantly, and one of the big things that to me is what are their targets, short and long term, not what is their employer's target, what are their personal aims, ambitions, and targets. And that I learned from people like you, from therapists, is what you expect, because there are many people, and I know you've seen this in rugby league, who have played their whole career with horrendous looking injuries on scans, um, and been in pain all the way through, but they've played at the highest level. So it doesn't mean that everybody can do that, because everyone is built slightly differently.
Yes,
But
I'm in total
it's
agreement with that.
about treating the man, not the scan, or the woman, and not the scan.
That's it. Well, yeah, I totally agree with that. I see a lot in clinic with some people with some really, let's say, extreme scan reports where it says there's a lot wrong, but they're displaying with very, very little symptoms. But yet you see
That's right.
somebody with a relatively normal scan and their symptoms on paper just do not make sense.
Yeah.
So it's good that
Uh,
you treat the man, not the scan. I've had an incident with yourself with that where I was not adamant, but I asked you for a second opinion on a player of mine that dislocated the shoulder and they had an avulsion fracture. And I think I sent you the scan report, and from that you said realistically the outcomes are very similar, surgical or non-surgical. So you're kind of risking somebody surgical for not a well for the output that they're going to get is going to be very similar. So you'd basically rehab that. Which, to be fair, that player is not struggled since. He had a few issues on the season that he was playing, but ultimately got back to playing a week or two after, and has seen relative little issues. So it's good. I'm with you on that perspective. With clubs, then I know myself. I've worked at a club. I know the demands and the constraints. Do you ever have a time where clubs are having too much of an input into the decision, or do you find it's mainly just the players' decision themselves?
of course. Oh, not just clubs, agents, particularly, very, very much so. More so agents than actually the clubs, to be honest with you, because again, you guys probably get more of the pressure from
Yeah,
the clubs than we do.
yeah,
So it's my simple thing is I make it very clear to the patient that my duty of care is to the patient, not their employer, and then we remind them that yours and the team doctor, the team physiotherapist, your interest is in them and not your employer. And I think that's really important for them to hear that. I think another thing in the decision making, I always say to them is do you have a mother, a wife, a girlfriend, a partner, a husband, a boyfriend? Speak to them because they're the ones who have your interests at heart. So it's very important that when have to make any decisions, medical decisions, that they do discuss it with those people as well and don't feel pressurized by one particular person or employer.
yeah. That's a perfect way of looking at it. We've had another player, close friend of mine, on the podcast, that after he had ankle surgery, and the constraints on his wife were bigger than the constraints on him as a rugby league player. She'd just given birth. He's there. He can't move. He can't help his family. So there is that side of things that people do need to look at, and it's a massively overlooked part.
Talking about wives and girlfriends, the one that you remind me of one particular one who, at the end of the season, he needed both his shoulders operating on, but he wanted to have them done at the same time, which means that for the type of surgery he was having, he wouldn't be able to wipe his own bottom for at least 3 weeks. And he had the most lovely girlfriend who, in the consulting room, said, "No problem, I'll do that for him." And I said to him, "You got to marry that one."
Yeah, I'm just thinking there. If I was in that situation, would my wife do the same? I reckon she'd say,
Exactly,
"We go one at a time.
exactly. And that
We go."
wasn't even his wife. Yeah,
Oh,
yeah,
wow, that is
that was
definitely a keeper. Um,
absolutely.
is there some myths around surgery that you wish athletes understood then? Because I get a lot of clients, players, oh, this needs surgery. And even though, say, I don't think it does, I'm not obviously in the best position to say if it does or it doesn't. But is there any myths around surgery that people need to understand?
Yeah, the word that you said, need. You never need. The only times you ever need it is, and possibly even not then, is for cancer and infection. Otherwise, you don't need shoulder surgery.
So it's a want.
It's well, it's about quality of life. So it's not life-saving surgery. It's quality of life surgery. Um, so that's, like I said, it's a decision-making process. And I think a lot of the time people think that seeing a surgeon means you're going to have surgery. Uh, However, most shoulder surgeons or honest shoulder surgeons, and my surgical conversion rate is about 10%. So as you know, so conversion to surgery is only 10%. I have to see 100 patients to operate on 10. Um, and that even, my practice is 60% athletes at the moment, and that's even in that group because at the moment, so for example, at the moment there's a lot of rugby union and footballers with in-season injuries, um, but um, it does you can use whichever statistics you want to take somebody to surgery or any studies, um, but that can have very big implications particularly for a footballer mid-season when they're fighting for their place in the team.
Yeah.
So that has to be balanced. If you look at the injury on a scan, you could come up with all sorts of statistics from multiple poor quality studies to make an argument for an operation. And that's where I think you see people more subspecialized in, for example, sport or trauma or arthroplasty, or so even within that particular joint.
That's
Similarly, mm,
Yeah, go for it. Go carry on. I'm loving this bit. I'm loving this information. It's just people don't
mm,
see the, like you say,
mm,
the constraints there of seasons. Yes, they might be fighting for stuff for the season, but they're probably fighting for stuff the season after, such as a contract,
uh,
day to day
that's
living.
Yeah,
Is there times there where
it's their job, and to be honest with you, I have a very very similar situation with self-employed builders,
yeah,
plumbers, decorators, very similar situation because this is their livelihood, this is their career. So
yeah.
you've got to balance all these things.
Is there a time where then, well, is rushing into surgery ever as risky as delaying it too long? Is there actual a sweet spot for surgery then? I know that might be a hard
So
question.
to be honest with you, no. I mean, there's it's very rare that there's anything that we can't sort out later on if needed. So yes, you could use studies to make an argument for early surgery for many types of injuries. I think the main ones that come in is displaced fractures. So, if you do end up with a non-union or a malunion, particular intra-articular fractures, that sort of thing, almost certainly you need an anatomical reduction for. In terms of soft tissue trauma, not quite so much.
Okay, that's a good way of looking at it. There's a lot of people that I'll see that they feel like it needs dealing with now. They want it sorted now, but it's good to know because I was always under the impression I might be right, I might be wrong here. It's just it's not my specialty. I've had quite a few players that have ruptured biceps, and they've been given time constraints there, as in
Mm.
if we don't do it in a certain amount of time, the tendon will start to dissipate or start to atrophy.
Dissolve
It'll start,
away or retract.
yeah.
Yes, yes.
Is
Uh, so, absolutely. And there are some studies that show early surgery has better outcomes than late, but they're not good. They're poor quality surgeries. So and you may know, and I know of players who've played rugby with complete bicep ruptures through their whole career without any problems. So um, you can use statistics as they are as part of a decision making process, but not to make the decision.
no, no. Well, yeah, with biceps, you're right there. I think I've dealt with three. Two of them was on the same player. So he had two retracted biceps, and I know after 3 or 4 days of it retracting, he was in zero pain because in theory the tendon's not attached, and he was doing chin ups 3 days
Yep.
later with very
Yep.
very good power and was playing the week after.
And
So
then,
it's
and I think the thing is, you want a surgical decision from somebody who has that experience of managing these injuries both operatively and non-operatively. So that's quite important, because it's very hard for someone who doesn't have a lot of experience with these injuries to not operate, for example, on something like that, because the literature, it tends to push towards early surgical repairs.
Yeah. That's one reason why I specifically like to use yourself and everybody else at the arm clinic. I think we've used Mr. Watts, isn't it, as well, that works there.
Hmm. Yeah,
He's
and sometimes, like you say,
he's
getting a second opinion, we do it with many other things in life. If we're getting a builder or an electrician, we might get another quote. There's nothing wrong with doing that as well.
no.
Yeah, yeah.
It's been very valuable on me as a therapist point of view, especially with things like yourself and Mr. Watts, where individuals the players very shook by the injury they've had. It's probably something they've not had before. We've sent them for a consultation with either yourself or somebody within the clinic, and they've laid out a couple of options that they're neither right, neither wrong. There's a non-surgical option. This is the expectations from this, or there's a surgical option. Um,
Yeah,
they haven't necessarily give
absolutely.
a recommendation with the biceps that I've sent, but the players then being able to make an informed decision of what they feels best for them, which is good. Some have had surgery, some haven't.
Absolutely. And I know Adam Watts very much works in that way.
Yeah, which I think I've sent 3 or 4 people to him, and it's outstanding. I think I've sent 2 or 3 private clients in my clinic to yourself, and quite a few players. So it's good to have those second opinions, and especially honest opinions that you can
Mm,
trust.
yeah.
I know I have a few clients in clinic that, again, my opinion might be wrong here, have been rushed into surgery too quick, and they get a
Mm,
reoccurrence of the same issue, not necessarily shoulders. I get a lot of lower back issues coming into my clinic, and I feel like the 2 or 3 surgeries down the line, but they're still in the same position. So it's those options and weighing up, and their quality of life is actually decreased from when they had their first, well, before they had their first surgery. So it's those important things that people need to look over. So once surgery's been finished, so to speak, on your side, what does a good rehab journey look from a surgeon's point of view? Then I know what it looks like from a therapist's point of view, but what's it look like from a surgeon's point of view?
uh, Pick the therapist. That's the most important thing.
Yeah,
So I would only send patients to physiotherapists that I know and work with.
yeah,
Um, so that's very, very important to me. So who the person is the key. Secondly, the from a rehab point of view, it's very much the old fashioned thing of getting movement and then strength and that way of doing things. No, that's out the window. What we want to do is get movement, get strength, straight away,
yeah,
in a safe way, so that
yeah,
any repairs are okay. Nowadays, our repair techniques are so strong, especially in terms of athletes, that they can start very early mobilization, very much the same as you would with an ACL. Um, so it's working with the therapist. So, I always say to patients, we each do a third. A third of what I do, a third is what the therapist does, and third is the patient, and we all have to do our thirds bit. Fortunately, my third is the easiest bit, because that's the hard work starts after the surgery, um,
yes,
and uh, and communication. So in terms of the so-called protocols, they're guidelines, they're not prescriptions, and fortunately, I've worked with many good therapists in different sports to come up with sport specific protocols for those particular sports. So you will have received the rugby one for pecs, and so they're all very specific, and then I'll modify them for the patient on the day as well.
yeah. I'm big with that. Key performance indicators from our side to make sure they're safe to progress, and most importantly, confident to progress. Um,
Absolutely. that's the number one for return to play. People always tell me what test. I said when they feel ready. That's
Yes,
the best test.
yes, that's because you can be ready on paper, you can be ready structurally, strength. We could have everything as perfect as it can
Absolutely
be,
right.
but if mentally you're not there, the chance of re-injury is just going to be high. You're going to be
And
overprotecting yourself.
it's not their fault. You do. We've had some guys, I'm sure you have, who are the biggest, toughest guys on the pitch, take the biggest injuries and give the biggest hits, but recovery wise are very anxious and nervous with the recovery because it's so unfamiliar to them. And there's no point in rushing them back. They need to be handled in the right way.
Well, where do you see athletes most commonly go wrong in rehab? Then, has there been any times where people haven't stuck to what they're meant to be doing? They think they know best. Is there anything that commonly goes wrong?
So again, it's really down to communication. If It's really down to the therapist. So with professional athletes, there'll be I normally have very good communication with the physiotherapist. So they normally know if something's going wrong, or if they're particularly with football, they're less confident with shoulders, for example, although they're becoming more. So they might communicate with me a bit more, and get a rugby. I always like to get a rugby therapist involved as well with that. Um, so communication is the absolute key, and I think part of that. And this is not just not our athletes, but our middle-aged athletes, gym goers, paddle players, things like that. Um, there, what we'll do is we'll make sure we'll ring them after surgery as well to reiterate all the early rehab. I like them to see their therapist within a week, or so, very early, and then make sure that ideally it's
Yeah, yeah. That's for me. That's so valuable. Um, I think a lot of people that I've seen that have had surgery haven't necessarily had those follow ups. They're so important for me for confidence through rehab. I could set the best plan in the world, and they're hitting every marker. If they don't feel like something's right, I can't answer that question for them. They're the only person that can realistically answer that question in their mind is the person that's performed the surgery. Joe Keys, yeah. Well, there's like I mentioned, Joe Keys was on the previous podcast. He had an issue post surgery. I'll say an issue. It wasn't an issue. He mentions it himself. A firework went off in the middle of the night, 2 days post surgery, and his dog jumped. So he threw his arm out to try and stop his dog. And he said he rang me straight away. It was quite late at night. I think I've just ripped it off the bone again. And I was just like, hold on a second. In my head, there is nothing really other than major, maybe road traffic incident that would rip that off again or putting you through the same thing. And I think he came and saw you. We organised something the next day, and I think you reiterated what I said is that is it's strongly attached. It'd take a lot more than that to make it go again. And from there, he instantly just settled, and then he was able to start to go back into his rehab. So again, anybody else struggling? Yeah, no. But also, I see it from my point of view as well that I'm not a shoulder surgeon, and I know little bits of what goes into it and expected recovery times, wound healing, expectations for motor output to return. But ultimately, it's your handiwork that's been done. If there's a problem with your house, that you normally call the builder that did the build. Yeah, it's reassurance. I tell you what's for me then, well, not for me, for everybody out there, what's one message you could leave for an athlete or anybody struggling with a shoulder injury right now? They're injured, they're worried, and unsure if they'll ever get back to doing what they can do. What's one message that you could give them? Yeah, no, unless it's the shoulderdoc.co.uk. Even then, perfect. That's a great bit of advice. A little bit of quick fire to finish. Then it's been great having you on. It's some great insights for me here as well. I've really enjoyed this. What's the most overhyped So overused, that's not very good recovery gadget or trend that you see right now that people come into you saying, "I've tried this." Yeah, well, that's not good to hear from my point of view. I've just bought a shockwave machine. No, I don't. It depends in what context it's used. As a standalone, no. A lot of the way that I think a lot of people use recovery boots, air compression boots, things that they'll think that, to be fair, a lot of devices, if used on their own, I think are overhyped. Because what people don't realize, I'm under the big impression that movement is key to anything. If somebody wants to get back playing sport, you can't have a machine on your shoulder playing sport. You can't have a machine. Yeah. So no matter how good those recovery tools are, you ultimately need to move better or move differently, move adequately. So yeah, the shockwave, I've got a shockwave, but it's used in conjunction with rehabilitation. Um, the brain is a magical thing, and the brain can do wonderful things. So a different type of stimulus is what I use it for. If I'm rehabilitating somebody with tennis elbow, for instance, um, we can stimulate things in a little bit of different way to get a little bit of pain relief, so we can start to work the whole chain from fingertips to neck. Perfect. And the placebo effect, I know the magic of placebo is it works wonders. It comes with confidence in telling people what they need, not what they need to hear, but the true honesty. This isn't going to solve everything, but it's going to help us settle symptoms. And if they start to, I'm not saying believe that, but if their mindset is this person's the right person for me, you'll get wins with it anyway. If you're not 100%, I'm with you on that. My price points that I've set reflect that. I've worked when I first started in clinics, charging very, very little amount, and I got people not turning up, people not doing this, not very many results. I've not changed too much of the way I work because I feel like my system works, but the price point goes up and people respect it a lot more and buy into it a lot more. So it's amazing. Um, what's the simplest thing somebody can do to aid their recovery? Yeah. If you weren't a surgeon, then if you weren't a shoulder surgeon, if you weren't one of the best around at that, what would you love to be doing? Nice. Any type of particular cars? Are we restoring cars or building your own? Okay. Yeah. That sounds amazing. Sounds like a friend of mine's job. That is his job. He restores classic cars and for clients, and he loves it. It sounds amazing. So I know obviously I've mentioned the shoulder.co.uk, but my understanding of that was obviously a little bit different. That's obviously for your patients and therapists. Yeah. Well, where can other people find Professor Lennard Funk to potentially follow what you do, how you treat clients, and potentially what you're doing car wise? Where can they see what's going on? Lovely. Well, it's been very, very good to talk to you, Leonard. Thank you very much for jumping on and taking the time. I know there's a few of my clients who can't wait to listen to this, and it'll settle a few expectations for them, especially one that's just gone through surgery. So very, very much appreciate it. Yeah, which is good. This is one reason. No, no. Well, I've had many conversations about that. Who was it? It was, I think it was the owner of Nvidia, the AI chip manufacturing company. He basically said that anybody who moves molecules from A to B is pretty much going to be safe in a job. Anything that isn't moving molecules, you very much need to start looking. But it's yeah, it's a different way of looking at it. But times will change. But yeah, thank you very much for joining us, Leonard, and thank you for taking your evening. Thank you very much.